My name is Dr. David Maddy from the University of Louisville School of Dentistry, and this is a mini series of lectures that I created for dental students that I title Functional Occlusion and Advanced Restorative Concepts. There are three major sources that I need to acknowledge. The bulk of the information comes from Dr. Dawson's book titled Functional Occlusion from TMJ to Smile Design. There will be some bits from Dr. Okeson's book titled Management of Temporal Mandibular Disorders and Occlusion, and there will be several videos and animations throughout the series that were donated and created by a company called BiteFX. And at the bottom right corner of each slide is an acknowledgement of where the source is. This is lecture number 3 in the series, and I title it Next Comes the Front, Anterior Guidance and Contact. I will do some repeating in this series in order to help in retention, and as the repeating occurs between lectures, I will speed up in my voice so that you have a chance to follow at a faster speed. But we're going to review first the inverted tripod concept that Dr. Dawson introduced. And if you remember, he said there were two critical stopping points for jaw closure and a perfected occlusion. The posterior determinants called centric relation, and then the anterior component, which is the anterior teeth. So consider the front 6 teeth to the 6 teeth. Think of it as a three-legged stool that's quite stable. These are critical stopping points. And remember, in a perfected occlusion, of which I told you that I like because it implies that something was done, an action was taken, and it is improved compared to an ideal occlusion, which sometimes means different things to different people. Why do we talk about this perfected occlusion? It's the most stable, most protective, most comfortable, and most predictable of all occlusions. Do people really have it? Not so much. So why talk about it? Well, we talk about it for this reason. And here is basically your treatment plan options, which will come into later on in greater depth. But you want to incorporate sometimes a perfected occlusion, certainly at all complete dentures, distal extension partials, extensive restorative procedures when they're anticipated, such as fixed removal, or implant combinations, any sign or symptom of occlusal instability, any sign or symptom of dysfunction or parafunction, hopefully during ortho treatment and splint construction. Why? Here we go again. It's stable, protective, comfortable, and predictable. Last week we talked about the back and starting our evaluation by looking at the condyles and centric relation. The TMJs must be comfortable and stable. And the key points in that lecture were two. One was that the lateral pterygoid has an antagonistic and a protagonistic role. It has a complexity, and when healthy, it functions in a synchronized type fashion. And the second was there is a critical stop for that condyle, and it's actually bone. Of course, there's a disc there, but that condyle is braced by bone between the medial pole, the head of the condyle, and the medial wall of the articular eminence. Therefore, being able to withstand high load and force. Think of it as an apex. Now we're going to go to the front. The third leg in the inverted tripod concept. And again, think of the front 6 teeth together, 6/6, not just the two as this picture implies. Principle number 1, we must have stable holding contact on the anterior teeth. They must touch, just like this animation is going to show. Now notice when I start this animation that the green lines in the condyle are in line with each other, which means that condyle is completely seated and that there will be a rotation in order to closure. And in this case, there will not be the dilemma that I spoke of at the end of the last lecture. So they're just going to come in and we're going to have full MIP. But when this happens and this closure does occur, we want to have contact on those anterior teeth. We want them to touch. We don't want a space to be there. It would look like this. If we were to put some articulating tape or ribbon onto the teeth and have them tap, we would see actually little marks in the lingual surfaces of the maxillary anterior teeth. And really, that is the reason for the cingulum, if you think about it. It's kind of just like almost like a horizontal shelf. And every piece of anatomy has a purpose. And the purpose of that is to create a shelf and for the lower anterior and sagittal edges to touch in a horizontal fashion. Principle number 2, we want to create anterior guidance that has immediate separation of posterior teeth. I mean immediate separation, not just somewhere along the movement, but immediately. And if we, again, were to put tape in and have the patient slide forward, then we would see the marks on the two centrals, let's say. Or if they went to the right or the left, we would see the line on the corresponding canine. This animation video will show how anterior and canine protected guidance work. And notice we use the word protected, and we'll address that meaning in just a minute. But as I start the video, you'll see that when you slide forward, your anterior teeth should make contact so that the posterior teeth are separated and have no contact. When you go to the right, when you go to the left, and using the canines for guidance, the same thing should happen. The posterior teeth should not have any contact, and the guidance should open the bite in the posterior, not allowing contact to occur. So why do we say immediate separation? So what I mean by that is as soon as you start to move in any position outside of MIP, then no posterior teeth should have contact. And the reason we want it to be immediate is because when the posterior teeth are not in contact, the elevator muscles are shut down. So we cannot get near the proprioreceptive input to create great force in squeezing unless the posterior teeth are touching. And so we were talking earlier about occlusion being a balance of force management between the teeth, muscles, and joint. We can see that if we can design it so that the posterior teeth cannot have contact when we're grinding, then we can have the benefit of destructive forces being eliminated. Of course, when we have our anterior teeth relate to each other, we need to do it in such a way that there is an overlap so that when you do protrude, there can be some separation and guidance. We call it anterior coupling. Principle number 3, the anterior teeth must be in harmony with the neutral zone. The neutral zone is the balanced position between the inward forces of the buccinator muscle and the outward forces of the tongue. And as this animation shows, the lip pulls back, the tongue pushes forward, and the anterior teeth end up in that balanced neutral zone. And the idea is not to put the edge of that anterior tooth too far forward, or that lower lip and upper lip will pull it back, and you will be violating the neutral zone. And if we have a little battle going on with muscles and teeth, then muscle always wins. So the critical importance here is that the sagittal edge of the maxillary anterior teeth are within the neutral zone and not too far to the labial. I'm going to let Dr. Dawson talk about that a little bit, and he's going to tell you how to determine the exact edge position of those maxillary anterior teeth to be in harmony with the neutral zone and the lip closure path, proper aesthetics and proper phonetics. So I'm going to give him a few minutes to explain to you this matrix concept that he talks of.
Now we have to follow a step-by-step process to determine each guideline in proper sequence. Here's the sequence that you have to go through for determining the anterior guidance. We're going to start with stable centric relation contacts. That means, you see, if you didn't have your posterior interferences out of the way, you couldn't even know where that spot is. You have to start at centric relation. There's a very good reason for starting at centric relation. We want immediate disclusion of all the posterior teeth the moment the jaw leaves centric relation and moves in any direction. If we don't have contact on the anterior teeth at centric relation, then it can't disclude the posterior teeth immediately. There'll be a gap in there. So we have to get that centric right for the front teeth. All right? That means we're going to verify complete seating of the TMJs to make sure we have no posterior interference and that we have anterior contact in centric relation. That's a verification. Okay, now we've got the first step and the most important step, incidentally, done for the front teeth. The second most important thing we have to determine is the incisal edge position. But we can't just go to the incisal edge. We have to determine the correct inclination of those anterior teeth before we can know the horizontal position of the incisal edge. And that starts with the upper labial contour. How do we establish that? That dimension right there. Well, that dimension right there is a continuation of the alveolar process extended onto the upper half of the anterior teeth. There's no change in direction. There's no bump. There's no bulge. It's a continuation of contour off the labial contour of the alveolar process. That's why when you take a diagnostic impression for your study cast, you absolutely must include the entire alveolar process as well as the teeth. Don't cut your impression short of that because you won't be able to do this. And that gives you that upper half. Now you're ready to do the lower half of the labial contour. And how do we do that? Well, we're going to continue that down and in until it does what? Until it is in the inner vermilion border of the lower lip enclosure. And that's going to allow us to find the incisal edge. Now, that means that in order to find that incisal edge correctly, we have to make it where it doesn't interfere with that lip closure path. Even just a millimeter mistake here will compromise your result here. So we are very fussy about where that labioincisal line angle goes on that anterior tooth. Now, here's an area that you want to be particularly careful about. Because if you get this line angle, the labioincisal line angle there, too sharp or too long or out too far, it's going to interfere with that lip closure path. If we get the anterior teeth in harmony with the lip closure path, the neutral zone, and the phonetics, they will always be at the best appearance that you can have. Now that I have a matrix and know where that labial contour is, I can now individualize the teeth within that matrix. We'll start with incisal plane. And it wants to line up with the lower lip. And many people have flat lips, so you'll have a pretty flat incisal plane. Some people have real cupid bow lips, very curved lips. You'll have a very curved incisal plane. Why is that so? Because this is related to the phonetics in the F position. And if that upper incisal edge doesn't strike the inner vermilion border along the whole width of the lower lip in the F position, why, it'll bug the patient. And it won't look right either. Now you can work out your anterior guidance because you have your starting point, your centric relation, number 1. You've got your end point, your incisal edge, number 4. Now you can work out the anterior guidance. Not until. If you try to do this before you have located the precise determination of where that incisal edge goes, then you're not going to get it right. I can tell you, guesswork just doesn't work. Oh, the patient may accept it, but you won't get the wow factor that you get, and you won't have the stability that you have by really getting this exactly right. So you see, we've worked our way around the complete form, and now we can just round off the cingulum, and we've completed it. So if you look at the view of the tooth from the side, you can just work your way around. Start at centric, and then you go to the upper half of the front, and then the lower half. Now we can work out our incisal edge. Now that we've got the beginning point and the end point, finish off with your anterior guidance, round it off, and you've got your anterior teeth. And every part of the contour, inclination, and position of those upper anterior teeth were determined.
So I had just a few examples of people with smiles that follow their lower lip. So if you think of the incisal plane as like from number 6 through 11 or canine to canine, in a highly functioning and anesthetic case, then they follow each other. So you can see Tiger Woods on the left, he has a very cupid bow lip, and his incisal plane of his anterior teeth follow that. And he looks good, he has a beautiful smile. If we look at the young lady on the right, she has more of a flat lip, and her incisal plane is more flat. And of course, Tiger Woods is a pretty famous guy, but the lady on the right is just as famous to me because that is my daughter. A couple more examples, and this is something I would encourage you to do. I like to look at news broadcasters, and I'll freeze the frame on them on the TV sometimes, and you'll see that the lady on the left has a very cupid bow, beautiful smile, and the incisal edges follow, and the gentleman on the right is a little flatter, and his incisal edge follows his lower lip. And then every now and then you'll see someone that doesn't look right. You see, this is more of a flat crowns that were made, and he has a cupid bow lip, and it just tends not to give us the best aesthetics. Principle number 4: create aesthetic anterior contours that do not restrict the envelope of function. The envelope of function is a three-dimensional space within which mandibular function occurs, determined by the outer limits of the mandibular anterior teeth in a normal chewing cycle. So it'd be like this. This repetitive muscular pattern is individualized per person depending upon the location of the teeth and their neutral zone. So it's their chewing cycle. And so the concept is this: don't mess with it. Don't get in the way with it. Don't impede on the envelope of function. You'll get into trouble if you do. It's a very common restorative mistake. And so it kind of works like this. The lingual slope contour determines the anterior guidance, the excursive pathway, and incisal length. And so in some people, it goes to the edge. And so as they slide on their anterior guidance, their envelope of function can go to the edge and a little bit around the edge of the teeth. Not on everybody, but on some. And the idea is if you do something in this section, like a filling or a crown or anything, you don't interfere with what was there naturally. Another way to look at it is on the left, we have a beginning lingual contour. And as this patient slides and in their anterior guidance, this muscular pattern develops, and we call that the neuromuscular envelope of function. That's what is individualized to them. If we look at the right, we're going to see that something was done. Maybe a filling was placed or a crown was placed, and it was made thicker there. So as a consequence, we're interfering with that envelope of function. So what happens is that muscular pattern will win, and it will want to try to go there, but it can't. And so you're creating a potential parafunctional problem that will tend to destroy and tear up teeth. Now that contour, that lingual contour is really critical and important. And so a good way to tell the lab how to create that exact same curvature on the lingual surfaces of the maxillary anterior teeth is to make what's called a custom incisal guide table. And this records for the dental lab the lingual slopes of the maxillary anterior teeth. Let's go through some clinical examples to see if we can make sense of this. Here's a case with a front filling that was done. It's really quite nice and beautiful. It's even hard to tell that it's there. But in a short period of time, the patient came back and had broken the filling out. So if we look at the markings when that patient bit and slid, it was adjusted so that it was only riding on the filling. Now, I might have gotten the MIP correct when they went into full closure, but the doctor did not check the excursion, the forward movement, and left it a little taller than what was there before, because you can see it's only marking on the new filling and not the original tooth. And as a consequence, it created a parafunctional problem. And guess what wins? Muscle always wins. In this case, that parafunctional problem occurred in muscle 1 and busted out the filling. And so this is a simple, easy example of encroaching upon the envelope of function. Don't do that. Anterior guidance, only filling encroaching in the envelope of function. This next example is a couple crowns, and they're kind of ugly crowns, but they're crowns, and they were done for some reason for this patient. And if we open up the bite a little bit and look at the lower teeth underneath it, you'll see this massive amount of destruction of the incisal edge that corresponds to the anterior edges of the crown. And of course, you might hear that somebody say or teach you that porcelain is abrasive and porcelain will tear anterior teeth up. And yes, it can if it's done incorrectly, but if it's done correctly, it won't necessarily. But when incorrect, sure, it can be very abrasive. And look at the destruction that has occurred. And so as I'm looking at this, I'm thinking to myself, what happened here? Where is the problem? And if you look at right there, you see that's flat right there. And from that, I knew that it had to have had a wear facet from the opposing tooth at some point in this person's life, or it wouldn't be flattened like that. So I'm thinking, and I'm assuming that those incisal edges on these new crowns were made longer than the existing teeth, and therefore never opened it such though that now that area can't touch. And so we've made those crowns a little too long. And I said in some people, the incisal edges get in the way of the envelope of function. So don't make them longer unless you know you can. Another example, a single tooth that's longer than the rest. And it's fair to assume that that crown wasn't made like that, that something has changed. And probably when that crown was put in, it was the same length. And if we look at the tooth underneath it, we see the massive destruction of the porcelain grinding, the parafunctional problem that has occurred from something in that crown that is just destroying those lower teeth and grinding them down. So let's look at the lingual contours of that crown and look how thick it is. You can just tell by looking at it compared to the lateral that it just is in the way. Again, it could be that when the patient closed an MIP, it felt good into a closure, but the dentist didn't check the forward protrusion and made that lingual thick. And as a consequence, we've interfered with the envelope function, created a parafunctional problem, and has destroyed those lower anterior teeth. This doesn't have to take very long. This is something that could happen in a couple years' time. Porcelain crown made too thick on the lingual, encroaching on the envelope of function. One more example, it's a 3-unit bridge, and if we look at it from here, you see there's some recession or some abfractions at the gingival margins of the abutments on the crown on the bridges. If we look at the lower anterior teeth, we see there's some recession and there's some abfractions in the buccal and the lingual as well. And if we look at the lingual of the bridge, you see that all these little groove marks, are from that lower anterior teeth grinding and grinding. And of course, the weakest part breaks. And in this case, the metal maybe was softer than the edges. And so you see the destruction that's occurring by that bridge made thick on the lingual, encroaching upon the envelope of function. So the goal then is to make the anterior guidance in harmony with the envelope of function. All right, let me give you a few guidelines for doing that. When only a few anterior teeth are being restored, a couple crowns maybe, or some fillings, then look at the adjacent teeth guidance, and if appropriate, copy the guidance. Make sure, though, that something wasn't done on a tooth next to it to interfere, but if you know they're natural teeth to natural teeth, then copy the guidance, like this. When that filling was done in the case on the left, they should have checked their protrusion so that it rode on the natural tooth next to it as well. Or maybe when those crowns were placed, rather than trying to make them tall and make them look better, just realize that that's not wise and make them the length that they were and create that anterior guidance so that lateral could then have contact again. So copy what is there. That way you won't be encroaching upon that envelope function. Another guideline for you is that steepening the guidance can get you in trouble. So here, example on the right, we can see that it's a pretty steep drop, and that can get you in trouble. You can do that, but you need to know how and when, and maybe even follow it with transitionals or temporaries for a while first. Shallowing the guidance, but keeping the posterior disclusion, gives the patient more freedom and comfort. And you can always shallow and not get in trouble, but then you can only shallow to the extent that the incisal edge allows you to do. without encroaching upon the neutral zone by making those anterior edges of the maxillary teeth too far forward. Shallowing. So let's have a summary of anterior contact. We want to have stable holding contacts. We want to create anterior guidance that has immediate separation of posterior teeth. We want the anterior teeth to be in harmony with the neutral zone, and we don't want to impede on the envelope of function. Let's look at it another way. Let's look at it by looking at Dr. Dawson's matrix. Principle number 1, stable holding contact point. Principle number 2, create anterior guidance that has immediate separation of posterior teeth, right here. Principle 3, anterior teeth must be in harmony with the neutral zone, that edge position, not too far to the buccal, not too far to the lingual, not too long, and don't impede on the envelope of function. And what that does is that incorporates often the edge as well as the lingual contour. So next week, we're going to go into the last section of the perfected occlusion topics we're covering, and we're going to talk about what's left in the middle, emphasizing posterior non-interfering contact.